All right. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Niazi. Dr. Niazi's primary focus is to provide mental and behavioral health care to nursing homes and assisted living facilities, focus on dementia evaluation and treatment, reduce behavioral issues, minimize hospitalization, medication management, therapy, decision-making, capacity, and family education, as well as counseling. She has privileges at many hospitals and senior living locations in and around the DMV area, the DC, Maryland area, and is a teaching faculty at the St. Elizabeth's Hospital. She's also a visiting consultant at the Baltimore Washington Medical Center Hospital, where she's directed the partial hospitalization program, managing a diverse team of nurses and psychologists. She is a part of the Maryland Board of Nursing and Rehabilitation Committee, as well as the Maryland Board of Social Work Examiners. Dr. Niazi finished her residency program in psychiatry as a chief medical resident from the St. Elizabeth's Hospital in Washington, D.C. And now it is my honor to request Dr. Niazi to begin today's session. Thank you.
Thank you, Manahil, for such a nice introduction. Thank you so much. So will I be able to see the students or no?
Yeah, so they can turn on their cameras. I can request cameras.
Okay.
But yeah, they're here and they're also on YouTube Live, so they don't have their cameras on from there.
Oh, okay. So, so Manahil has given such an extended introduction of me. I think in this 1 hour, I welcome everybody, and then we can have a follow-up sessions maybe sometime again. Manahil has been trying to schedule this, but I had some kind of work-related conflicts that I was not able to come, and I had to cancel a few times. I was sick last week, but I said, no, I have to do this session. So this 1 hour, I'm going to focus the first half an hour in explaining to you all why I chose the field of medicine, and then particularly psychiatry. And then in the next half hour, we will focus on some of the interesting cases. Unfortunately, I don't have slides. I usually would like to kind of this session to be more interactive, but if the students feel slides are helpful, we can always come up and I can make some slides and give it to Manahil and she can email it to you all. So and then I understand at the end will be Q&A session. So just a few minutes on who I am and where I come from. So my name is Rubina Niazi, and I was born in Pakistan, but I was raised in Oman, Muscat. I'm 8th of 9 siblings, so I'm second last in my family. When I was growing up, I always looked up to my father as my inspiration. So I was from a very young age, I wanted to be a doctor, actually. And on one side, if we look at our parents, every parent wants in Pakistan and other cultures, some of, our cultures, everybody wants their children to be doctors. Those are the most respected professions. Actually, that's why they want that. So, but I really had a lot of passion for that, and I wanted to be a doctor. So after my high school, and my father really kind of supported me and encouraged me. He always told me stories about that if he had to choose a career and he goes back, he will choose to become a doctor. So that really kind of touched my heart. I'm very passionate about my dad. So I got accepted in med school. We applied my father applied to Fatma Jinnah Medical College, and I got accepted there. So I started my career, I would say around 88, something like that. And I finished in 93. Fatma Jinnah is the only college in Pakistan that is all females. Although I didn't study it in, my high school was with co-ed, but I went to a female college. So just to tell you about Fatma Jinnah was founded in 1948. Okay, so before the name of the Fatma Jinnah, it used to be Balak Ram Medical Center, and then they changed it to Fatma Jinnah Medical College. So lately they have changed the name again. It's kind of a Fatma Jinnah University right now, and they don't have principal system. They have chancellor, vice chancellor, that type of system right now. So I got accepted. The teaching hospital that is attached to Fatma Jinnah is Gangaram Hospital. So when I went there, it was a huge cultural shock first for me. I grew up in Oman, very hard in the beginning, but I really kept my spirits. And every time my father will call, I want to go back to Oman and don't want to stay in Pakistan. But, you know, in the midst of that, my father died unexpectedly. So he died when I was a first year, I think, student. So that really kind of stirred me up. And I stuck to his dream and I said, now I have to do it for my dad. So I worked hard. And after that, I started liking college, Pakistan. I love Lahore. So I finished my med school around 94, something around that, 1993 to 1994. I came back to Muscat. I was doing my house job and I got married, came to US. At the end of the 90s, I did my exams, USMLEs, a very, I'm not sure, some of you probably are, foreign medical graduates in this teleshadowing, but it was a very intense and very difficult process. But if we have the drive and the motivation and the hope, Allah really helps us to go through it. So I did my exams, made a network of new friends, very good friends. Some of them are still friends like sisters. And then I got accepted in St. Elizabeth Hospital in 2003. That's where I started my residency. So everybody asks me every day, why did you choose psychiatry? Why did you choose psychiatry? So psychiatry, first of all, what is psychiatry? Psychiatry is a field of medicine that really evaluates, treat patients with mental illnesses. And psychiatrist is that field of specialty that provides those services. So, they always make a joke in Pakistan. I don't know, my audience are all from Pakistan or from other countries. So, my so-and-so was a doctor in Pakistan, but she's a psychiatrist in the US. So, mental health is not accepted as it is, but I love my work. There are a few things that the psychiatry is different than any other field of medicine. You have to, your take home should be that you really have to like psychiatry to go into psychiatry. Otherwise, my teachers used to say, you have to like your work. Otherwise, it's a marriage you have with your work. And the marriage is very bitter because most of the time we spend with work if you don't like it. So my father did a lot of social work, and psychiatry is the field of medicine. I feel like we work like a social worker, we work like a detective, we work like a lawyer. So we have a lot of interfaces with a lot of fields of medicine. When we see a patient, as a whole. And sometimes we are the one that will dig into those patients, things that the other field of the medicine were not able to, and we help our colleagues to figure it out, what's going on with our patients. So it is a very diverse field. So I love every day of my work. I enjoy my field. So still I get asked this question over and over. I've been practicing psychiatrist for the last 15 years. So in the residency, I did my externship also at St. Elizabeth. So I was very familiar with the system. So St. Elizabeth is the hospital that was founded in 1855. It goes that back. And it used to call, that's it. It used to be called as, I think, the government hospital for insane. So when it was founded, and this was the first federal founded psychiatry hospital in the whole US. It had two campuses, West and East. If I don't know, some of you, it rests in DC, southeast of DC. If anybody has visited, it has two campuses. So the West campus is all, so in the beginning, it had all the fields of medicine, surgery, medicine, psychiatry. But I think after some time, they closed one campus due to financial or other bureaucratic reasons, I'm not sure. And the East campus was the one that was only functional. And so it's a huge campus. So if you see some of the old movies, there are some movies, I'm blocking on the note. They started a program that was programmed around St. Elizabeth. If I remember the name, I will let Manahil know, and she will let you know. It aired a few years ago, and that was all picturized in St. Elizabeth Hospital. So it had several buildings where people used to live there. It was like a long-term care. They would have their sort of a more treatment as well as psychosocial rehabilitation. But now it's only the forensic hospital and the acute care hospital that is there, and all the residential part is slowly dissolved due to financial reason. So I graduated from my residency program in 2007. So during my residency, I always had passion for CL psychiatry. What is CL psychiatry? It's a consultation liaison. I think Manahal has written that I was a chief resident. So during my chief resident time, also I learned a lot about. So we had two components, two parts to our chief residency. One was the admin part, and the other was the teaching part. So I always enjoyed teaching part. So then I really loved consultation liaison psychiatry, because this is a subspecialty of psychiatry that interfaces with, we usually evaluate patients on the medical and the surgical. In other words, patients with comorbid medical problems, and we provide mental health services to them. So I had really a lot of interest. So psychiatry residency is a 4-year program. So the first year program is based on, internal medicine, neurology, and then we do some psychiatry. And second year is all outpatient, and the third year is CL, and the fourth year is all CL and the outpatient, inpatient. It depends. Different programs have different type of setups. So my fourth year is mostly elective year. So I took a lot of elective in CL. I did my elective at Washington Hospital Center. I loved it. They had the best burn center. So you learned a lot from them. Not a lot of hospitals have burn center. They have burn centers. So I got a lot of, so I really wanted to pursue my career in that field. So I applied, got accepted I applied 2 places, Georgetown and University of Maryland. So University of Maryland offered me a pre-match, and since it was closer to my home, I accepted that. It was a 1-year fellowship, which I graduated. I'm board certified in psychiatry and CL psychiatry. In the past, they had CL psychiatry, then they changed the name to psychosomatic, and then recently they again changed to CL, because psychosomatic is not a right term. I feel it doesn't give you, if you tell psychosomatic, that just is not the kind of word that we would want to use, because we don't want to scare patients. So once I finished my career, I started my career in an inpatient. Then I wanted to do something flexible. So I chose the long-term care assisted living facilities. So it's a great setup. It's geriatric, but it provides a lot of CL work. So I really loved it. I still do inpatient. So my work is divided into several, because being a CL psychiatrist, I feel like outpatient for me, and it could be different for my other colleagues. It just gets boring. I also think that that if you are in several fields, for example, inpatient, outpatient, and CL, so it just gives you a diversity of your clinical experience. So I work at inpatient. I do some weekend work at inpatient like every few months. I'm still with Baltimore Washington Medical Center, which is part of University of Maryland. Started my career there, still with a CL type of work in geriatric population, so which is a long-term care assisted. Initially worked for some people, but now my own business, and I do my own work. I think so the geriatric population in between, also I did some forensic work. I was a chief psychiatrist at pretrial complex, learned a lot from that at Baltimore, but I thought this was not for me. So I went back to my my geriatric population and the other work. So when I was a chief resident and during my third year, we never had a strong leadership or a strong teaching from a CL, which kind of struggled. All the other residency programs had it. So I made in my to-do list, this was one of the things that once I stabilize my career, I'm going to go back to my program and provide free teaching to my residents. And that's what I've been doing for several years. I teach a CL course every year from July to August to my second year, third year residents. Free. That is my volunteer work as a regard to my residency program. So I still do that. So I guess my recommendation, and if you take anything from this 1 hour of a talk about psychiatry, is that if you really like this field, then you choose. I think I always advocate for psychiatry. I think we should choose psychiatry for several reasons. It is a field of medicine that is very, very interesting. As I said, we are not only doctors, we do a lot of other works for patients, social, lawyer work, detective work, everything. Then it is very flexible field. You can choose a lifestyle that you want. It also has a lot of job opportunities. So I get every day so many calls, texts, if I'm interested. So, and it has money, that's more important. That is also important, right? We just don't want to work. We have to make income too, our families too, right? So I always advocate for psychiatry. It has a lot of subspecialty. As a psychiatrist, you're a specialist. And then if you choose field of medicine, if you choose subspecialty, then you super specialize. This is the only field that has 4-year training program, which kind of makes a specialist. And then you choose another if you want to. Oh, yeah. Okay. So if you really want to, one field is CL psychiatry, the other is geriatric. You can do geriatric fellowship. You could do addiction psychiatry. You could do forensic psychiatry. You could do child psychiatry. So, there are several fields, and there might be some more emerging fields. I went to a conference not too long ago in Boston. There could be more coming up, but these are the main that have training programs and that have board certifications. So you could choose anything depending on your interest. I can tell you that a lot of people go into a child and adolescent psychiatry fellowship. CL psychiatry was my passion, but you don't have to do a fellowship to be a CL psychiatrist. After 4 years of residency, you could still practice as CL psychiatrist. So it depends what you want to do in your career. So that's kind of the whole ballpark of my training. So my fellowship is from University of Maryland, so I did, as a part of my fellowship, it was broken down into a transplant clinic. So I did a liver transplant clinic. So where we saw patients and we did evaluation for the patients. What are these evaluations? These evaluations are, they have a team of evaluations, and psychiatry is one of the team that they want to make sure, because a lot of the liver transplant patients have addiction issues. So they want the psychiatrist to clear them so that they can put them on the transplant list. So we come up with our evaluations, and then at the end of the evaluations, we don't say we recommend or don't recommend. We never write that. We say these are the positive things in this patient and these are the negative things. So the positive things are that he has support, he's willing, and the negative things are that there's still risk of relapse. So and then it was broken down into, I also did a HIV clinic. So I have a lot of work with HIV patients. And then I did a dementia care clinic at VA hospital because I wanted to go into long-term and see how they are. So that's why I did. So that my fellowship. And then of course, the other part of the fellowship was broken down in a general surgical, medical, OBGYN. I have a lot of passion for female health, and I did a lot of work as a part of my fellowship as as well as a part of my current work that I do a lot of work with women health. I have a lot of patients in my outpatient psychiatrist, majority females. So women health is another thing that that I think we can make a difference in their lives. So this is my psychiatry training. Manahil, is it like the questions in between, or we will go at the end?
We can go at the end.
Okay. So I guess my take home for you all, your take home for this is that if you really like the field, you should go for it. This is the best field. The other day, I was in a grocery store and I saw a young couple, and so they were from Pakistan, and I was shopping. They were shopping. I was coming out of my hospital call, and they saw me. And the girl was doing internal medicine, and I'm not sure what it was, but he came to me. He's like, "Oh, you're a psychiatrist." I said, "Yeah." It's like, "Oh my God, it's so hard to get into psychiatry." So I don't know, because I'm not doing that much. That I don't see that side of the picture, but it is becoming very competitive. But you should all, I think, I would advocate all of you should go into psychiatry, and you will love it. So that's kind of the whole kind of a synopsis of my psychiatry training. I had two to-do lists, which when I was very young, when my father died. So I also wanted to, I didn't give any slide to Manahil. I think she told me to give me. So I also wanted to do some charity work on my father's name. So now I think for last 3 years, I've been working on it. And I was able to, with the help of Allah and with the help of my family, my husband and everybody else, I was able to make NGO, and at an international level, it's named as Healing and Caring. And then I'm gonna, under that umbrella, I've started already the process. I want to make a charity hospital in my village, because it's a small village where my father and we all come from. And it really needs a lot of health resources, especially in psychiatry. Actually, I did a medical camp last year. This beginning of this year, I went to my village and I did a camp on women health. And it was so surprising for me that every female that brought their files to me, like 70% of the things were psychiatry and somatic complaints. Everybody, even young girl had a joint pain, young girl couldn't eat. So this is some of the things that, I wanted to do, and I wanted to give back to my own a place where my father comes from. So I'm working on that. It's a long process and long work. But when there is a will, Allah finds a way for us. So that's some of my other work. So I'm happy that I'm starting the first road, the first steps of my dreams that I wanted to do after 15 years into the. So the take home is that anybody can achieve their dream. We have to work on it. And then once we reach to that, once we have to stabilize ourselves. I always tell my patient and others too, when we are in an airplane, they tell us, put the mask first before you help others. So there's nothing wrong in stabilizing ourselves first so that we can help others. It's not being selfish or anything. So work on your career so you can give back to whatever your dreams are and whoever your dreams are for. That's my first part of the lecture. I hope it serves the purpose that. So now we will talk about cases. Okay, I have like bazillions and bazillions of cases that I did throughout my career. So the first case that I'm going to talk about is when I first, it's very close to me because I first started my career with that case on an inpatient unit. I still cannot forget that case. I had a young boy of 20-year-old who presented to the hospital with worsening of mood symptoms, depression, hopelessness, worthlessness. And then he had some anxiety. There are some addiction issues involved. So there were no prior suicide attempts. So he presented to the hospital, and given his age, he was around 20 something. So he got admitted on an inpatient, and I was the attending for that patient. So so anytime a patient get admitted on the unit, first of all, we have to do all the medical workup. So the medical workup will include all the blood tests. We want to make sure that we do a urine drug screen. So there's nothing, anything in the urine that could be causing the symptom of depression. Then we want to make sure that we rule out thyroid problems so that that's not causing the depression. Once we rule out all the medical part, then we focus on the psychiatric part. Most of the diagnoses in our field, we do not have a test. It's a clinical diagnosis. That's another thing that people sometimes have hard to understand. So we sit with the patients, we evaluate the patients, and we interview extensively. In this interview, we have to get every possible history. So if a patient is coming with depression, so I will screen for depression. Have you been feeling depressed, hopeless, worthless? How long the symptoms lasted? And then I'm going to screen for all other psychiatric review of symptoms, which will include anxiety, which you just ask the buzzwords. Have you ever felt anxious, worried? Then you go into bipolar. Anytime a patient present at age 20 or something, you got to screen for the bipolar. So bipolar is anytime they have an elevated mood, which doesn't make sense, and it was more than normal. People could have normal high mood. So we have to make, which is abnormal. So you screen for that. And then you screen for any other illnesses like schizophrenia, where we ask them questions about psychosis, which means, have you ever had unusual experiences? So these are the buzzwords. I'm not going to go into the teaching of how to interview. We can have a separate session if somebody is interested. But the bottom line is, once you have a patient, it's a clinical interview, and you rule out all other possibilities, and then you come up with your diagnosis. So the diagnosis for major depression, you will make if a patient has been depressed for almost more than 2 weeks with feeling hopeless, worthless, even sometimes your patients are not able to give you a classic book history, but you can get a feel of it. Depression and anxiety are always comorbid. It's okay. The treatment is same for both. So we don't care if they are, but we just want to screen so that we understand that the only problem is we don't want to miss bipolar. So I diagnosed this person as a major depression. So we treated him with one of the medication. Selective serotonin reuptake inhibitors are medications like Zoloft, Prozac. I'm not going to go into more details because that's not your level, but these are the medications that we treat. The medications start working, takes a few weeks. That's another problem in our field. Any medications for depression and anxiety does not start working because what they're doing in our body is building up serotonin, and it takes several weeks before they build up. But the whole point is that we provide the safe environment for the patient, and we start the treatment, we observe any side effects, we stabilize the patient, and then we take the patient to the next level. So the average length of stay in the hospital is 3 to 5. Hospitals are rated with length of stay. So there's a lot of pressure for us to discharge the patient after, some time. So we, in old days, it was easy. People tell me that they could have patients on psych units for months, but not anymore. So there's a lot of pressure for us to discharge the patient. So these patients, we could still keep it for a week. We could justify it. We could get the insurance coverage. So we stabilized him. And then since the symptoms were so severe, so if you have a patient that has a severe depression, always it's very important that we connect with the family. We provide that family meeting. So we want to make sure what type of support. He lived with his grandmother. So we had a family meeting with his grandmother, and we made sure that he gets discharged to a safe environment. And then we connected him to a partial hospital program. So I was the attending on an inpatient, and I also ran the partial hospital program. What is partial hospital program? It's like you go to a hospital and then you go to a subacute care before you go home. it is that type of setup for you. So partial hospital program is a day program from 9 to 3, Monday through Friday. There's a team of psychiatrists, social workers, case managers, others. So it is divided into medication management, which the psychiatrist does, but then they provide psychosocial support and structure so that we can transition them back to the communities. So they have groups, several types of groups. They work with the occupational therapist, so that can help them with the work related issues. So we also, while they are in our PHP program, we transition patients back to their work. Few days we give them off, they go back to their work and see if they're able to. So that's a partial hospital program. So it is on an average 1 to 2 weeks. So once they complete that, they go home. So this patient was in partial hospital program. I'm sorry, my throat is getting dry. Do I have something? Okay. So and then we stabilized him. We had another meeting in the partial hospital program, and we discharged the patient. Okay. So guess what happened? I discharged the patient. Patient went to so you have to make sure that the patient is discharged with an aftercare. So so we scheduled the appointment with the therapist, and he was discharged, and while in our PHP, while we are monitoring him, and then we did not see any safety issues. So once he gets discharged, he goes home, and a week later, he buys a gun and he kills himself. So here I am, just starting my career. So the point I'm making is that you will have challenges in your career, but that doesn't mean that, if an internist has several patients and they get a heart attack, not all of them are saved. Few of them are going to die. Similarly, in our field, no matter how safe you practice, no matter what you do, your patients are still going to die. So they're still going to kill themselves. So he bought a gun and killed himself. I was devastated. I couldn't go to work for one day. So my boss, I still remember that time, wanted me to take, time and just take it easy and not worry. And then what happens? Then the risk management starts, right? Now we go back to our notes and see, what did we do? Did we do anything wrong? So then the case is discussed in ethics committee and other committees of the hospital to make sure that we did everything. That's part of the process. It's nothing to do with anybody. It's part of the process. So what we did, after several, discussions and then those meetings, it was established that we did everything in our capacity, but the patient did kill himself. I don't want to scare you. You all are students trying to choose a career, but it happens, right, to the best of us. So suicide is something in psychiatry that no matter how safe you are, people will still do it, those who want to do it. But what is important is for us, a take home is that I will do everything in my capacity to make sure that my documentation is fine, that I am discharging the patient to a safe environment. Patient has aftercare, patient has a family support, because it's not about just patient. In reality, we have to protect ourselves too. It's both. It's, one thing is that the patients are getting help, and the other thing is that we are doing everything in our capacity to help our so that we don't get sued. I just found out from a legal lecture in the Boston meeting that every year 12,000 psychiatrists get sued, but that's fine. That's not a big number, as psychiatry is so vast. But the bottom line is that how many of them, if they're sued, doesn't mean anything. Anybody could get sued, but how many of them really had made a mistake and harmed the patient? It comes to that at the end of the day. So alhamdulillah, I've been practicing 15 years. So far challenges do come, but as long as you practice right, it goes right away. So that was the conclusion of my first case. So the teaching point from this is that no matter how safe we practice, we still can have people who would commit suicide. And that's a very important in our profession. And then the second point is that simple presentation, no prior suicide attempts, people can still do things. So that's kind of it. So I feel like I don't want to do an intense discussion of the cases. I would just provide the synopsis and see so that you guys can get some teaching point to your level. I believe in providing the teaching to a level that my audience are. I can't give you a level of a resident that I'm teaching right now. No, that's not right. So, you want to get an overview of psychiatry and what we do. So, so now I'm going to share a few from my outpatient practice. This was an inpatient, and then I will tell you a few from my CL practice. So, and dementia practice. So, just kind of a synopsis, some teaching points. So in my outpatient practice, I do one. So in the outpatient practice, majority of the patients that you will see are depression, anxiety. I see few bipolar, none schizophrenia. And then we see a lot of attention deficit. It's kind of emerging field right now. So, but a ballpark of your patients in the outpatient setup are anxiety and depression. So it is like every person that comes. So what is the biggest complaint everybody that comes to your office has? Oh, I was doing fine. I'm not able to do my work. I get overwhelmed. I'm not able to sleep. So these are some of the buzzwords that the patients, and then of course, you will conduct an interview, an extensive one. I've been into this, so I do my interview in 30 minutes, I'm done. But for you all, it will be at least an hour interview where the chief complaint and then the history of present illness. The history of present illness will have everything about the psychiatry. So you will screen all psychiatric review of symptoms. Then you will also ask about their prior histories of if there has been any treatment. Then you will go into if there's any medical problems. Then you will go into the social history. You want to know where your patient is. Where was your patient born, raised? So this will give you an overview about are they working, not working. You will do a mental status examination. So the half of the mental status examination you do while looking at your patients. And then there are several layers of the mental status examination. Like other fields of medicine will do the physical exam. We will do the mental status exam. That would have several layers. I'm not going to go into the mental status exam because if it was my med students right now, I would do the mental status exam because that's most important for the med students. But you just need to know the mental status exam is we look at the appearance of the patients. We look how they're speaking. If there's anything extraordinary, we observe patients while they're talking to us. And then you ask the buzzwords, right? Their mood. We have to look at their speech. All of these sections will tell us something about our patient. So psychiatry is all clinical. Just talk. That's why with this teleworld, our practices is more busier than ever right now with the COVID, I think, pandemic. So, and then you come to an assessment and treatment program, treatment plan. So at the end of your evaluation, you should be able to formulate a diagnosis. So it is okay to have a differential diagnosis, but differential diagnosis cannot be 10 for treatment purposes. You could have a differential diagnosis of 10, but you can have a differential diagnosis of 10 for treatment. So my next step would be to diagnose. So usually it's depression and anxiety. So I had seen a patient not too long ago that one of the reasons that I see a lot of females is that they say, oh, I'm pregnant and should I continue my medications or not? So she presented to my office in her 30s. She presented with a symptom of depression, feeling depressed, not wanting to do anything, no safety issue. She had overwhelming feeling at work. She was doing relatively well at work, but still she worked. So then the next question is the triggers. The triggers of the works were that she worked in a very male dominated setup, and it was very overwhelming for her. This impacted her sleep. She was not able to sleep. She's had poor appetite. She lost some weight, and this has been ongoing. And then on the midst of that, she becomes pregnant. She comes to me, and then she was on a medication called fluoxetine. So I evaluated her. I diagnosed her with depression and anxiety, and she was on fluoxetine, a smaller dose. What I did was, so at the end of my evaluations, I have a discussion with my patients. Hey, this is what's going on. And so she was on fluoxetine. My recommendation to her was that let's increase the fluoxetine from 10 to 20 and see what happens. So the next question was, she's pregnant, what do I do? So the bottom line for all the females that are pregnant, I just came from Boston and I took a special workshop in women health. The bottom line was, I always tell patients, a risk of untreated mom is way more than the risk of the medication. That's it. This is it. If you compare the risks of the medication on the baby or in the postpartum period, the risks are very, because we are comparing them to the general populations, the risks are very small. But if the mother is not treated, and then they can make that decision. I provide them the data that I have and they can make their decision. So so I said, my recommendation is not to get off of the medication. There is no true contraindication for any antidepressants. There's only one contraindication, that is a mood stabilizer medication for bipolar patient. But if this is working for you, I would want you to stay on it. And then we will work closely with your OBGYN and they can monitor you. What are some of the risks? Baby could be low birth weight. So what? We'll work on it with the OBGYN. But if you are treated, that would be much better than. So her husband was an ER physician, believe it or not. I'm giving you the story that how much still mental health is not viewed as it should be. So she goes home. She was stable on Prozac. And then her husband says, no, she has to change to another medication, sertraline, which is Zoloft, because the OBGYN said there are more data they have. There's no such thing as more data in one. They may have more data in one, but the impact at the end is not hugely different. I just had that thinking of mine more got solidified when I went to this new update to see that what if I'm missing on anything. So the husband changed, they pushed it. So that's another thing. We struggle with what the patients and their families want. We cannot practice 100% what we want, what is best for our patients. So I had to change our medication, believe it or not. And she really did poorly in first pregnancy, struggled to the postpartum. She had postpartum depression. So as soon as she was over 1 year or 2 year, or 1 year, I think, she said, oh yeah, I want to go back to fluoxetine. I put her back on fluoxetine. She becomes pregnant again. So she has now 3 children. So I gave you that example just to give an idea. So now I told her, now my patient was very strong. She said, no, I am not going to change my med. I'm going to stay on my current med. And that's what I'm going to do. So she stayed on the current med. The pregnancy was stable and the postpartum period was stable, and she did so well. So the bottom line is that if the patients are stable on certain medication, even they get pregnant, we cannot be changing them around, because the risk of changing is way more than the benefit of new bringing addition to the case. So I see her still, she has 3 children and she's doing so well on the fluoxetine. Fluoxetine is a medication that has been in the market longest, highly researched, prescribed highly in all the population, including children. So it's relatively safe. When you have more research, it is relatively safe. Although, there will be a lot of black box warning, other things, but we're not going to worry about that. As long as we have a good discussion and they have an ability to understand my discussion and make their decision. That's kind of a case of female in my practice. I'll quickly go, I think we have 10 minutes over my case in the long-term care. So in my other hat that I wear, which is my favorite hat, and I practice 70% of my practice in that population is my geriatric patients. So majority of the patients I do not specialize in dementia itself. I always, this is a neurology, but I specialized in dementia related behaviors. So that is 90% of the population that we see. Nobody is diagnosing them there. It's been diagnosed, started on meds. So the behaviors are what we deal with. So the patients the typical example is a 75-year-old male. I'm just going over a synopsis of what I see so that you guys can understand, was doing relatively well at home. Family say, oh, my father is driving, doing everything fine. He gets either a pneumonia, he gets either a urinary tract infection, he ends up in the hospital. So when he ends up in the hospital, now he comes to a rehab center. He's a different man now. I think what the family miss, people, when they're patients at home, they miss the fine cognitive impairment, which we call as mild cognitive impairments, where people could be repeating things over and over, misplacing things, and repetition is a main buzzword, or getting lost. So they don't focus on that because overall, this population is able to hide well, and they're able. So once they go into the hospital, a small insult to their body declines them to the next level right away. The decline is so huge that it is hard for people to understand. So my role is very tough. So you have to like it to be that. My role is when they come to the nursing home, now everybody's angry. My dad was just fine. What happened? My dad was fine. Now he's agitated. He's not drinking. He's not eating. He's not allowing staff to take care of them. So I have to help the family understand the process, what happened to your dad and why he's agitated and what did we miss. And then now, unfortunately, he has dementia. When they hear the buzzword dementia, it really doesn't, they don't like that word. So they said, my dad can never have. So part of it is that we help and educate and provide support to the family, and at the same time provide support to the staff at assisted living or nursing home. So that's kind of the main thing. So geriatric population is very tough because if you look at their meds, this like a whole page of meds. So what do? So you look at the med now, you're going to put another med, which is going to create more polypharmacy for them. And then most of the treatment that we have in mental health are not FDA approved. So we use off-label indication medication for treating agitation. Number one cause for agitation and restlessness is a decline in their memory, is change in their environment, and also anxiety and depression. So we hit them with those medications first, but they're not the medications that are going to take right away effect. So there's a struggle. So we have to come up with medications that can stabilize their agitation, help patients so that, because they're hitting, kicking, right? It's like, people are touching them. They are foreign to them. They don't like it, right? If somebody touches me, what am I going to do? I'm going to defend myself. So they're defending themselves. In their defense, they hurt people, they hurt staff don't want to work with them. So we have to come up with strategies that are not book labeled, but others to help the agitation, convince the families, and then work on stabilizing them. So that's kind of the most part of my work. And the other significant complaint in that population is they're not eating and the weight loss. I see a lot of patients for weight loss because they want me to rule out depression. So once we rule out depression, so what people are not realizing, memory impairment really coincides with depression. A lot of the symptoms are like depressions. We don't realize it, but they are. So they kind of coexist. So I have to make a determination that their symptoms are related to dementia or depression. So it's kind of both 50-50. Majority of the time, it is the dementia because they declined, their appetite went down, they don't want to eat well. So this is a new environment, so there could be depression. So these are some of the challenges in the nursing home population that I see. But then there are good stories. too. When we see patients, we stabilize them. I had a patient that really was very agitated, and we were able, and the families really come and appreciate you too, that you changed, my father's life, you changed this. But then majority of the time you kind of have a lot of struggle in prescribing medications in that world. So, geriatric is a population that is challenging, but it's very, I love it. I think it's not difficult to words. It's just you need to have that. So I think that concludes my lecture, because, I kind of, and one of the most common, I want to touch on my CL work too. One of the most common complaint or consults I get on my CL service is, anytime people get admitted on the medical floor, and they have some remote diagnosis of depression, they get labeled. They will call me, Dr. Niazi, can you please shift this patient to psych? He has schizophrenia. And when I go to see and do the workup and look at the patient has delirium. What is delirium? Delirium is an acute confusion state due to medical problems. For example, if they have UTI, they could get confused. If they have pneumonia, any infection, any change in their body, whether it's infection or metabolic, can lead to confusion and agitation. So half of the time we are telling our colleagues, hey, this is delirium. We cannot, it's unethical to take a patient who had schizophrenia but is delivered to a psychiatric unit. And it is not legal also. So we have to treat them on the medical floor, but provide support, go around them, see them, help them understand. So that's also CL work, is a lot of detective and a lot of liaison work with several teams. So we work together. We don't get defensive. So psychiatrist has to be flexible, has to be willing to work with all the teams, and not take anything, personal. Then only, and whatever you see in the hospital, in your outpatient, you help them, but then you have to leave it there. You don't bring it home. You have to unwind yourself. Otherwise, it's going to be hard. So half of the time I teach everybody and tell them, hey, you know what? So a lot of my friends ask me. So I said, I have to put everything in one compartment in my brain. I love my work. I have passion in my work, but I'm working from 8 to 8. And when I go home, I don't want to think about work. I love to watch TV and dramas. So that concludes my lecture. Thank you so much, everybody. Who's the host now? Is it you, Hamza?
Yes. I'm going to be doing the Q&A. So
okay.
Yeah.
I hope this was helpful. I'm not sure. I didn't come up with slides. I had my own ideas, and I wasn't well either. But we can have, if our audience are interested, maybe we can have in the first quarter of next year, I can work with Manahil and we can have more.
All right. So thank you very much for your mentorship and teaching, Dr. Niazi. I'll begin the Q&A session. My name is Hamza. I'm a student in Seton Hill University and Lake Erie College of Osteopathic Medicine's BSDO program in Pennsylvania.
Very good.
So to start off the Q&A, there's currently a behavioral health crisis in the shortage of inpatient psychiatric beds in the States. And given your pressures to discharge patients, where do patients go if they need to be discharged but will still need further assistance or close monitoring?
Okay, very good question. So we also struggle the way that the audience are asking me question. So majority of the time, believe it or not, some patients get discharged home if they have a good family support. And then if these patients have addiction issues, we try to link them with the addiction programs. Okay, and if there are a lot of addiction centers, so the social workers are able to help us to find that resource. Then the third part is the partial hospital program. We ideally would want these patients to go to a partial hospital program, but we don't live in the ideal world. As we're saying, there's shortage of things. So I think majority of the time, these patients end up at home. And so one thing we do, and we kind of make very much emphasis, is that we connect them with an outpatient provider, and then we connect them with a therapist. There are also outpatient programs that are walk-in clinics right now. Shepherd Pratt is the biggest system. So we try to hook them. So we don't let any patient go out without connecting them to core services agencies where they could have follow-up. So at least if the problem arises, they can get readmitted again.
Thank you very much for that answer. The next question we have is, how do you reduce hospital readmissions?
So having a good mental health care. If everybody identifies that they need mental health care, first of all, so is this question regarding the patients who are existing patients, probably?
Yeah.
Okay, so the existing patients is that, the best way to reduce the hospitalization is if they are in a setup where they have a psychiatrist as well as a therapist. Okay, so the psychiatrist and the therapist work together. And patients who are really, so what I usually do, I feel patients who are really severely depressed, I come up with alternative treatments for them. So that I don't, so one of the treatment is, if it's a brittle depression and is not getting better, I don't want patients to go into the hospital. So I give them other resources. For example, there is electroconvulsive therapy, ECT therapy, which people don't like to do it, but that's one option. And then we have transmagnetic stimulation, which is an electrical stimulation of the brain. We call it TMS. I send a lot of my patients for TMS. Patients who are brittle and don't want to go to, they're refractory. So I reduce the hospitalization. So those are two factors. And the third factor is having a good care, and also being mindful and looking into their symptoms, not like just writing a script and getting them out of your office. We won't be able to know. So, and also sometimes a therapist, if we are at a pressure of seeing X number of patients, which can happen to psychiatrists, if they're working in private, not their own practices, but the other working for somebody, you have to see a certain number of patients at a certain time. So what we can do is then we work in collaboration with the therapist. So the patients will see therapists, and the therapist can alert us. And then we bring, one of the other factor to reduce the hospitalization is I bring in a family meeting to see their support. I do that a lot.
Thank you very much for that answer. You mentioned a little bit about talking to families when it comes to suicide. But how do you help with families who may be grieving after losing a loved one to suicide, or is that not your job?
Well, it is always our job, actually. If a patient is ours, right? So I really, when my patients commit suicide, so far I just had one case, but I think the best, if it happens to anybody, the best thing is to bring them together and have a session with them. This session is based on the grief counseling session. And then what I would do is I would identify, the best thing is for help them understand the process. Processing is very important. So if they don't process, they're not going to grieve it. Sometimes people shut down. So you have to help them to process, to talk about. So I do a session with them, and then I make sure that they have some sort of grieving counseling sessions. We connect them to, if they have a therapist, or any other therapists that are in our practices, to give them few counseling. Therapists do the best. No matter how much psychiatrists practice psychiatry and know everything, we learn. My program is very psychodynamic oriented. Where I graduated, we learned everything about therapy, but still the therapists are the best that in this field still, because they do more. So I do that with them, and then you kind of bring them back together periodically to see where they are standing, but don't leave them alone.
Thank you very much for that answer as well. How do you approach families who may be stubborn with giving their loved one the care they need? So, for example, they may not allow their loved one to go to psychiatric hospital, or they may not allow their loved one to take antidepressants or anything like that. How would you approach that?
So, well, that is the most tough question. So we have to see the age now, the age group where it's coming from, right? If there are children, and the parent is interfering with the treatment that could be life-saving for them, then we can report them to Child Protective Services, which we don't do. I don't see any children. I'm not a child psychiatrist, so by choice, I would not do a good job, but that's what happens. Or first, we want to bring them to understand why they are refusing. We want to educate them about it and tell them what would be the risk benefit and what could be the consequences. Majority of the time, they would agree. And then sometimes they don't agree. If we think there's a safety issue, we override. But the parent has to give a consent for us to treat. If it's a borderline, we can't do anything. But one of the other thing is the school. School is getting impacted, then the parents will take an action. So that goes to parents. Adults who can make their own decisions. Anybody 16 and below needs parent or somebody, or if they're not married, so we have to have that consent. But anything above 18 can make their own decision, as long as the family, if they're making their own decision and they're willing to work, we do treat them. But if they are 18 and above and they need treatment and they're understanding, the buzzword is they are understanding the risks and benefit of the treatment, and they choose not to get treated, we cannot treat them. However, if I have a safety issue, my ruling will overrule that. So I will send them to the hospital. I can call the police. I can emergency petition them and get them to the hospital. Older patients, geriatric, that is bulk of my practice. We keep pushing for helping the patient's family understand. But I did have one patient that the family was so demoralizing and very bad about mental health. The father was very bad, but they would not allow me to treat her. So, I had to sign off on that case. So we try to educate them, help them understand, but we need consent. We cannot treat them unless they give us a consent to treat, because these patients do not have the ability to make their own decision. So 70% of the children are good. They would want their parent to be comfortable. And then one of the other factors that influence the treatment, if they are in a nursing home or assisted living facility, that administratively there's a pressure on the family, because if they don't agree and the patient is getting worse, they can be kicked out of that facility. But this is how we deal with it every day.
Thank you very much for that answer. The next question I have is, we are really interested in your NGO work, and we want to learn more about if you had used telemedicine for it as well, given the expansion of access to care via telemedicine.
So my NGO work, you guys, that's how I understood. You wanted to know more about my NGO work?
Yes, please.
Okay. So I was as I said, I was in med school first year, maybe 18, 19, when I had this, when my father died. So I made, a kind of one of my promise that I will do my best if Allah helps me to do that. So finally, I think 3 or 4 years ago, we started the process. So my husband is the bread and butter of this, because a lot of the admin part, he helped me through. So to make an international NGO, we had to come up with a plan where we make a company first here. It's some name. I even don't know what that name is, because I'm not that great in admin name. So first we have to be certified here before we can go international. And there is a name for that. My goodness, why am I blocking? It will come to me. Or I'll let Manahil know later and she can text you guys. So we made that. And then after that, we applied the NGO process of security. So they really want to make sure. So then I have to come up with a name, and we had to write all in that process what I want to do for my NGO. And then the government of Pakistan approves it, whether they are accepting for me to submit the paperwork or not. Once that paperwork was submitted, then I did everything through lawyer. I had a lawyer here and I had a lawyer in Pakistan. So once that is done, then the next step was the NGO went through extensive scrutiny. I don't know. There are a lot of I feel like there are a lot of shady things that happen under NGOs, but people like who have a right intentions get the scrutinized most. That's how I feel it. But I didn't give up. So it took me 2 hours. Finally, they cleared me from Pakistan, and then it came to embassy of Pakistan here, and then they had to do whole search for me here, and then they approved it. So it just got approved at the beginning of this year. So I had already bought land in my village for my NGO. In order for me to apply, I have to provide them the whole structure. So what am I doing? So the land and everything has been purchased already. So my next step, I'm going to Pakistan, and I want everybody's prayer. I'm going to Pakistan next week. And my next step is to get my land, kind of organized so we can start the first process. It's a few-year program, because I want the support, stronger support from my, family. So we are towards the retirement age so that I can give more work. But the idea is to provide the urgent care. So the urgent care would be all the initial screening of the patients and, transport them to the nearest hospital. So we are still in the beginning process.
Thank you very much for that answer as well. Here's a question regarding differences between countries like America and Pakistan. So, do you believe that America and other Western countries have a worse mental health epidemic than countries like Pakistan? Or do you believe that the issues are just as bad in non-Western countries and they just fly under the radar?
So that's a good question, but I don't know any data to support my answer, but I can support the answer based on my experience. So I think I recently started some work in Pakistan. I have not done a lot of work in Pakistan, so I will take the example of my village that I did mental health, women health seminar and education. So I think the second part that in the Western world, it goes more under the radar and it gets more treated, more, people have more awareness versus in Pakistan. But Pakistan has, I would say, a similar epidemic for mental health that probably here, but it just doesn't get to that level because people are not able to get health. How would they get mental health?
Thank you very much for that answer as well. And there's 2 more questions left. So reflecting back on your journey, what has been the favorite part of your career thus far?
Say that again, Hamza.
Reflecting back on your journey, what has been the favorite part of your career thus far? So what has been the part of your career you love the most?
Yeah. So the favorite part, right?
Yes.
Yeah. So my favorite part was when I was graduating from my residency program, and I could reflect back that how much my father wanted me to be a doctor and and make a difference to this world. So that was the most favorite part, graduating from my residency program. And I think, no, I would take back the most favorite program. The most favorite part was when I got the match. You got matched. In the residency program. That really kind of was very, very much. And then the my journey, 4-year journey to be a psychiatrist. If I reflect back, I loved that part. It was very good, and becoming a psychiatrist.
Thank you very much. And for our last question, how do you manage your work-life balance?
Okay. So I think the most important part, if I look at it, is the support from your family. If you have a support from your family, you can do anything, right? That's the baseline. That's the pillar, in my opinion. So I will tell you how I balance. I took care of my father-in-law who had dementia at home. God bless his soul, he died. My mother-in-law still lives with me. So I want to make sure that, I work every day, like 10-hour day of work, because I like to work, not like I have to work, but I like to work. So I set aside times so that I can catch up on my home errands too. I don't want to neglect home errands, but the support from the husband is very important, or the spouse is very important. If my husband was not supportive and he'd been picking or stuff, then of course it's hard. I would still try to keep the work life balance, but it would be hard. So it's a team effort. If your family is doing half of the work at home, then you can do the rest. So he helps me a lot with a lot of home errands, and then I help a lot with a lot of other things that I need to do as a female in the family. So if you have time and you have your priorities, I think anything is possible. If I can get it done, anybody can get it done.
Thank you, Dr. Niazi. These are all the questions we have for today, and we really appreciate you taking the time to mentor us today. I'd like everybody to please give a warm thank you to Dr. Niazi in the chat box for this incredibly informative session.
Thank you so much, Dr. Niazi. That was really, really helpful. We learned so much. And I know that as I'm interested in looking into more rotations and exploring different fields, you're right, that psychiatry really did open my mind, especially your mention of Shepard Pratt and the need for psychiatrists, especially in Maryland. And so I really appreciate your work as well in the Department of Health with the different boards, social work examiners. So it's really inspirational. Thank you so much for taking the time. I really, really appreciate it.
Of course. And let me know. I'm willing to take the feedback from my session if it was not helpful, or there are some things that students wants me to do, or let them know more. I love to teach, though. It's just that the time crunch makes it harder, but we can do more in the next year.
Thank you, Dr. Niazi. Thank you so much. Really appreciate it.
Thank you, everybody. Best of luck.
Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. So the link for the quiz for this session is now live. You'll need a 70% or higher, as always, to pass and receive certification, and the link to the quiz is being sent in the chat now. And now for the future session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, November 5th at 10 a.m. Eastern Standard Time, with our physician mentoring us in psychiatry. Also, we have a special session coming today at 12:30 p.m. EST, so be sure to tune back in. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes the speech shadowing. Thank you.
Thank you so much, everybody. Thank you.